Those are a great series of talks, and I'm sure there's lots of good questions in the audience. So come on up to the microphones, and let's give these guys some tough questions and see what we got on the first microphone.
Yes, thank you. Very nice videos, by the way. My first question is with regards to the calcanectomy. Sorry, Frank Bowling, University of Manchester. I'm a little perplexed why you would want to disentangle the Achilles tendon. And probably out of the few that we've done in Manchester, I've yet to see a tongue fracture. That's my first question.
So you're going through the same internal struggle that we went through for years and years and years, and I can tell you that that the data now proves that there is no correlation between outcomes and amount of bone you resect. And that directly applies to trying to preserve the Achilles tendon insertion. And there were two very detrimental things that happened when we tried to not do the right surgery in exchange for preserving the Achilles tendon. First, we didn't take enough bone, so we couldn't close the wound, and we ended up losing the limb because it would get reinfected because we couldn't get tissue to tissue. And second, even if we did close the wound, we would end up with a calcaneal fracture that was quite debilitating. And it was fairly routine that we had one of those two outcomes. And then we changed our practice and we became more aggressive with the bone that we took out. It doesn't feel right. It doesn't look right. It doesn't seem right. You're biomechanically destroying that rear foot. But the data, at least our published paper now, shows that the outcomes are equal between the two groups, if not a little bit leaning towards aggressive bone resection. So you have the same struggle I have. It just doesn't seem right.
Absolutely. I'm struggling with the AFO, I think long-term AFO, with regards to transfer lesions, the fact that the patient is in this cast or appliance. But, I mean, I've yet to see the data. I think the next question is with regard to the stats, the chap on the right. Why on earth would you resect all of the tibialis anterior tendon and not to split it in half? I mean, you talk about the rein technique, but you're removing the medial rein and just replacing it with a lateral rein.
Yeah, I think that's a really good point. There are times that a split tibialis anterior tendon, I think, is a bit better. With patients with neuropathy, maybe higher body mass, I think you're asking a lot out of a tendon that you're already doing a lot of abuse to. I would hate the idea of transferring a tendon and then it's not enough. And I think with proper shoeing, a foot that pronates a little bit too much is perfectly fine in my book versus a foot that still happens to invert more than I prefer. I want that whole tendon as strong as we can make it.
So where is this inversion coming from once you've removed the medial portion of tibialis anterior? What is giving you this supinatory movement, not true triplanar movement, but certainly supinatory movement?
If I understand your question correctly, you're asking what is it that makes it invert?
Absolutely.
I would say it's vector pull where it happens between that subtalar axis and the rest of the show parts joint in front of it. Those are joints that will invert if you let them. And if the tibialis anterior is the only thing pulling and there's nothing else pulling laterally anymore, it's going to invert. And I know clinically we see that a lot, especially with a lot of the biomechanics studies and the pressure studies that we do with our colleague, Dr. Bijan Najafi. So this is what we see happen. So we want to get it to invert. We basically want to bring our evert. We want to get that tendon across the imaginary axis over to the lateral part of that foot, which is why where I used to put it in the lateral cuneiform, I now take it even further. I put it in the cuboid.
So why wouldn't that just be a stat? Out of curiosity, why I'm struggling with the concept.
Yeah. Sorry. So the stat, that split tibialis anterior tendon, I think that it's less predictable and it's going to put up with less abuse in a larger BMI patient that's already neuropathic and things like that. I think with a smaller kid, like I know when we do these mission trips with clubfoot, we're more likely to do a split tibialis anterior for those smaller kids because as they grow up, their tendon has time to get stronger over time, whereas a full-grown adult who's already got issues, I want them moving sooner and I want a big, strong, healthy tendon that's, I feel, more reliable. Haven't published anything on that.
I'm going to have you guys fight it out outside. Microphone number 2.
Dave Griffin, question to Dr. Steinberg and Dr. Giovinco primarily. With the transmetatarsal amputation and the idea of using the balancing of the tendons, any experience or thoughts in taking the extensor digitorum longus and tying it back down to something to be the other horse rein back again? And then secondly, the staging of when you do that. You've done your primary procedure to get rid of the infection, and you're trying to figure out, do I go back and do this a later date after I let things heal, or do I go ahead and do it while I'm in that third or fourth day post-surgery and I feel like I've got the infection out, when you're going to stick an implant potentially inside the cuboid or something like that to tie down the tendons?
So I'll take the first stab at that one. I'll tell you, I have the same concern you have about putting an implant in. We generally will stage it by 3 days, 4 days from the previous procedure. We'll have hopefully negative cultures to show that when we go to finally close that wound, if we feel good enough to close it, then we should feel good enough to make a secondary incision and treat the mechanical problem at the same time. Nothing wrong with perhaps waiting a few weeks to close your amputation as a separate stage and come back later, but in an effort to minimize anesthesia, we generally will do it similar to what Nick had presented, where we do it at the time of closure. I would tell you, just to throw out there to mix up this question even more, we talked about split versus total transfer. We're doing more and more now at Georgetown of just simply lengthening the tibialis anterior, so leaving the insertion intact, not doing a transfer at all, but lengthening it. We all know when you lengthen the tendon, you weaken it by at least one muscle strength group. I think secretively we're kind of sort of getting the same benefit that we got out of the transfers, but I know that there's a lot of power to the transfer, and that's going to become a subjective decision. Is if you really have a foot that is so significantly inverted, the only way to correct that's probably going to be a total transfer.
I think I'll say that was actually a really good question, and I know that we've talked about it. We've had some rounds with Dr. Armstrong and our fellows and stuff where we've talked about that extensor digitorum. So I do imagine a scenario that I could see myself maybe trying one day, where maybe we did a TMA when we knew it was clean several days post-op. What if we went back in there and found those individual slips of the digitorums and maybe sewed them into the distal stumps of the metatarsals? Would that help? I don't know. I haven't done that, so I'm kind of hoping somebody else will try it first and then I can learn off them.
I'll let you know.
Hey.
Dr. Gibbons, I've got a lot of help from the Medicare administration in doing non-invasive vascular testing, and I've had officials tell me you really don't need to do vascular testing. If you do a good examination and you use your pedal pulses, and if it's even more involved than that, then you could do an arthrogram or arthrograph. How do you feel about this? I feel between two rocks, to be honest with you, because I deal with a lot of diabetic patients with neuropathy and with early peripheral vascular disease. And I find that non-invasive vascular testing really gives me a guideline as to how the patient should be treated. But it seems that the Medicare guidelines, they look upon non-invasive vascular testing like unless you have a gangrenous toe, unless you have a cold foot, it's not needed.
Well, I think right now the problem with all of this is the bank is pretty much broken, and what really is the important thing is to do a really good history clinical evaluation. What they're not going to continue to cover is non-invasive, 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 and going from one test to another. And they're looking at it strictly from a cost basis. So I think the important thing is to keep it outpatient. And I agree with you. I think these tests are complementary to your clinical judgment, but I think a lot of time we kind of use them for the medical legal aspects, but I think the important thing with all of this is neuroischemic ulcers are more common than what we think they are. And so if you're making the diagnosis and you're just not sure, then that's where the test can help you.
Well, I follow up with if I find that the patient has night cramps and is vasoconstricted, I'll put them on vasodilating drug to start out with. and if it's more severe, I will refer the patient to a vascular specialist. But at least it gives me an early indication as to the status of the patient, rather than having to wait for an end-stage effect.
I think part of what he's touching on is the fact that screening ABIs is not considered at this moment a justifiable test, and it's a very controversial subject. It was looked at again by the U.S. Preventive Services Task Force. They gave it an inconclusive grade. Their concerns are that it could lead to over-interventions, based on people without symptoms treating.
Oh, no, but the patients that I treat and the patients I do the test on are symptomatic.
Well, if they're symptomatic and they have then you shouldn't really have a problem getting Medicare coverage.
That's putting down the right diagnosis code.
Right.
It was recommended many years ago by one of the ADA committees that every diabetic over 50 should have an ankle brachial ratio, and I think this is what is that going to lead to. I think, again, clinical judgment and all of these tests are only to support what you think is going on clinically.
David.
These are terrific, just terrific discussion. We could say so much, good Dr. Finlow, my 10-year-long Mancunian friend, but let's talk about this. When you take the Achilles tendon, I don't know why you're so excited about cutting the Achilles tendon.
Very excited.
But because, I mean, if you let it fly, this is not the end of the world, Dr. Finlow. Perhaps an interesting follow-up study. Oh, sorry, Frank. I was Andrew Finlow is who I would always argue with. Mancunian either way. But Andrew, one nice follow-up for you in Georgetown would be to follow these patients, maybe a year out, and see if they have actual plantar flexury strength. And I will tell you, I'll bet you $1 that almost all of them do have plantar flexury strength. The body is remarkably plastic, even when we damage it by cutting the Achilles tendon, because it binds down to all of that fibrous tissue. You still have a lever arm. Now, I've noticed...
This might be historic, Dave, but I agree with you 100%.
God bless you.
It might be the very first time, but I agree with you 100%.
We are
Somebody gets that on
Yeah.
tape.
Let's take a picture.
This moment is being recorded.
And now I've noticed that there are two the flow folks, the one that's very hirsute and the one that's bald next to him, have been falling asleep because they look like they're post-call, and I know the one on the left is. But to that end, on these calcanectomies, gentlemen, and you've seen a large number, and the numbers are quite similar to our friends in Georgetown. When do you just cut off the leg? When should you do that? And because I think it fits into what both of you are talking about, and particularly you, Miguel Montero Baker.
Yeah.
You're asking me when I cut the leg?
Yeah, man. I mean, come on.
That's a good question, I guess. Definitely, I was actually going to do a question before, but I will answer you in this way, and I think that one of the reasons why that surgery probably did that well was because actually that patient had phenomenal arteries down below. And so it's hard for me to think with or without the Achilles being an issue, which for probably 10 minutes there I had no idea what you were talking about. It was the fact that if you do have an orphan heel syndrome, or if you do have ischemic topography of the foot, you're going to have very serious trouble in trying to get anything to work there. And you and I have been trying in some of these cases where we do get some degree of perfusion, and then we go in and we do this massive cuts, and at the end of the day we end up doing a BK. So to echo Dr. Conti's comment in last session, I do believe that there are a certain group of people that maybe you shouldn't even think about the idea of doing that too. And maybe the alternative of talk, it's such a wide array of things that have to be put onto the table, clinically speaking, because you could probably temporize them and do wound hospice on some of these frail patients and maybe not even touch them, because why do a BK? If it's really not a big deal, maybe local optimization of care done. If it's somebody that has fantastic arteries on the other hand, and even if they're 83 but they have palpable pulses, maybe go for it. They're going to have a great. the gray becomes the middle, and that's when I'm not sure what the answer would be. And so I'll segue my answer with a final question to you, which would be, do you take into your algorithm their vascular status, and when is your cutoff for saying, I'm not going to try to do this, and I'm not going to try to retaliate against the Achilles tendon?
Yeah, I think you're right. We probably did get a little carried away. It's fun for Dave and I, but this Achilles tendon talk is secondary. But it's an interesting surgical point because it used to be so focused that do everything you can to avoid the Achilles detachment. But you're very correct. The whole reason someone forms a heel ulcer is either severe mechanical problems or immobilization with ischemia. And majority of those patients have significant ischemic concerns, and if they don't have an angiogram that looks as beautiful as the one that I showed pre-op, they probably are really better off with a primary amputation. And that's something that we're trying to get better at, making that initial decision rather than putting them through 6 surgeries to get that answer. But I do think there has to be a very critical look at that, and particularly challenged if you don't take advantage of that system from either medial or lateral calcaneal branch coming down, you probably have no business attempting to do a partial calcanectomy.
John, I got to disagree with you about, unless you're saying ischemia from pressure, not just macrovascular ischemia, because I think the leading cause of heel ulcers right now are people being admitted to the hospital or a step-down unit, dead in the bed for a couple of days, people and no sensation in the heel, and they come in with a problem on the front of the foot, and they leave with bilateral heel ulcers.
Oh, absolutely.
All right, last question before the reception.
I know that not all these cases were diabetic and neuropathic, some were just ischemic, but in those who are diabetic and neuropathic, are you seeing the 10 or 12% wound infection rates that Dr. Wukic reports for diabetics with neuropathy in any foot procedure? Nobody gets infected.
Wound infection rates after some of these procedures.
The one comment I would make, wound infection after revascularizations, and they talked about it in the session before this, is that patients who have significant ischemia, again, it's controlling sepsis first. We are not good debriders in this country, and people do bypasses before they drain infection, and sometimes the infection will really be kind of mired because diabetics don't respond like you and I would. They don't get elevations in the white count. They have a abnormal inflammatory response. And as soon as you do the revascularization, mainly with open, but you can see it with endo, all of a sudden the patient becomes septic. And those are the people you have to be ready to take them immediately back to the OR in 10 hours, 8 hours, because you've woken the bacteria up.
All right, John and Nick, at the end, after these extensive operations, how often do you have a bad wound infection?
How often do we have a bad wound infection? I'll have a bad wound infection if it wasn't clean going into it. If I didn't do my job and stage that partial calcanectomy and be picky about when I decided to do my final procedure, I'm going to fail every time. But if I've got near negative or negative culture growth and we have blood flow, it's kind of a no-brainer we're going to succeed.
Okay.
So, to the important notes, please visit the exhibitors in the Dolby Ballroom and enter to win an iPad. Get a minimum of 15 signatures on your prize card to be eligible. Details are in your notebook. Tomorrow morning at 7 a.m. to 7:45 here in this ballroom, there will be a symposium supported by Innovacin, Cleaning, Irrigating, and Debridement with Puricin Plus RX. Also, there will be a Friday morning workshop supported by Dermasciences from 8:30 to 10. Outside under the pavilion, a novel amniotic tissue, amnio-XL membrane, and amnio matrix suspension application. So please join us now for a reception with the exhibitors. We appreciate the exhibitors. They come, they support us, so please take a moment and help support them. Thank you.
Great.